We are live.
A very good evening and warm welcome to iFocus Online Lecture 517, the eighth in the series of eye and systemic diseases. Today we have Dr. Soumyava Basu from LV Prasad Eye Institute, Hyderabad, to speak to us on eye and systemic bacterial and fungal infections. He completed his MBBS from Seth GS Medical College, Mumbai, his MS Ophthalmology from Topiwala National Medical College, Mumbai. He later went on to do his fellowship in vitreoretina at Sri Ganapati Netralaya Jalna and LVPEI Hyderabad. He's also done a short-term fellowship at University of Cambridge in Laboratory of Molecular Biology, Cambridge, UK. He is also the awardee of ARVO Pfizer Collaborative Research Fellowship in the year 2013. He's a section editor in Uvea and Inflammation in the Indian Journal of Ophthalmology. He is currently the consultant in retina and with uveitis and also the head of uveitis services in LVPI network. He is an author of 110 publications in peer-reviewed journals and 10 book chapters. He's also the proud member of the International Uveitis Study Group. He's a reviewer for nearly all major ophthalmology journals and principal investigator for several multi-centric clinical trials. His clean areas of research interest are in immunopathogenesis of ocular tuberculosis and the role of autoimmunity in infectious uveitis. Who better to have you to teach us on this topic, sir? Thank you so much. Over to you, sir.
Thank you very much. You can hear me clearly?
Yes, sir.
Yeah, then I'll share my slide. Right. Is the slide seen now?
Yes, sir.
Yeah. All right. So the topic for today is infections in the eye that are affected by systemic bacterial and fungal infections. So in this title, the word systemic is very important because we are quite familiar with eye infections that are localized to the eye. Okay, so we deal with all kinds of infective keratitis, endophthalmitis, and a whole lot of infectious diseases. But today's focus is on those that are associated with systemic bacterial or fungal infections. Okay. Right. So, like I mentioned, most of the sampling that we do, microbiological sampling that we do, comes from all these that are shown in the picture here. Okay, so they come from the cornea, most of all, then maybe from the lids, conjunctiva, vitreous, rarely the aqueous. And then there are those cases that come from the lacrimal gland or from the contact lens, etc. Now, all of these are amenable to microbiological sampling. On the other hand, the type of infections that we're going to talk about today, majority, not all, but majority of those are not amenable to microbiological sampling, and therefore we need to apply different strategies to diagnose these infections. So these infections are mainly in the inner eye, in the retina or the choroid. And when I say choroid, I also mean the ciliary body and the iris, so the entire uveal tissue. And the way these infections localize themselves in different cell types within the eye, that decides the clinical presentation of these infections. Now, this is described in a lot of detail in this review that we wrote a few years ago in Ocular Immunology and Inflammation. But to put it shortly, I've taken this table from that review where I've shown the different types of target cells for different types of organisms. So, for example, Mycobacterium tuberculosis mainly goes into the macrophages. Okay, so it will, it will be forming granuloma wherever there are macrophages within the retina or the choroid. On the other hand, Mycobacterium leprae not only goes to the macrophages, but also to neural cells. But there is one thing unique with Mycobacterium leprae. You know that these are superficial infections. They affect the skin and the superficial nerves. So they like to survive in low temperatures, wherever the temperature is low on the surface of the body, which is why Mycobacterium leprae in the eye is more likely to be seen in the anterior segment as a chronic anterior uveitis or a scleritis rather than a choroiditis or a retinitis. So the type of cell that the particular organism likes to be in decides what kind of clinical manifestation comes out of it. I hope this concept was understandable. Now, there are a few other points that we need to remember when we deal with bacterial or fungal infections of the eye that are associated with systemic infection in the body. So there would be a focus of systemic infection somewhere, and a thorough search should be made for those kind of systemic infections. Now, these infections may be occult, so they may not be clinically very manifest, or they could be a very clinically manifest infection. For example, a patient with pulmonary tuberculosis who comes to you with a choroidal tubercle, that is a manifest infection, or a person with an endogenous endophthalmitis who comes with a uh, uh, you know with a urinary tract infection, that would be a manifest infection, or uh, a person with a placoid retinitis in the retina who also has a let's say a penile ulcer, that would also be a manifest infection uh, in that patient. On the other hand, a lot of these infections, and I'm going to discuss a few of them, will have occult systemic infection, and we need to be alert about the possibility of such occult infection. On the same lines, the evidence that you get from the eye may be definitive in a few cases that we are talking about here, which means you may have a microbiological or a molecular evidence of that infection. But in the majority of the cases that you treat in the eye, the evidence of infection is only ancillary. So you may have certain clinical or imaging signs in the eye, or you will have to depend on the presence of a systemic immune response against a particular infection that will help you clinch the diagnosis. Of course, knowing the patient's immune status is very important, because that will help you decide what kind of infection you might be dealing with. And the eye may not be the only organ. There can be multiple other organs that may be involved in that infection. For example, the brain is commonly involved in a lot of infections that are involving the eye. So we need to be alert about a multi-organ involvement and not just the eye. So I think this is a very important slide, and it's critical that you keep all these factors in mind when you deal with bacterial or fungal infections associated with systemic infections. So here is an example, and this is a picture from a time very early in my career. But the person who took the picture, did a very nice job. You can almost see that there's a white thing which is protruding into the vitreous. And the moment you see such a, white retinitis lesion which is protruding into the vitreous, the very limited differentials that you have. This was a 64-year-old pseudophakic male who came with a sudden drop of vision in the right eye. The patient also had a history of rheumatoid arthritis for a long time and was under immunosuppression. Now, this itself gives you a clue that you might be dealing with some kind of focus of infection here. Now, since this is a retinochoroiditis, the first thing that comes to your mind is toxoplasma, but the protrusion into the vitreous makes you think that this could be candida. And this pre-retinal clump is, what I call as the protrusion. So this went for a vitreous biopsy along with blood and urine culture and the toxoplasma serology, which of course was negative. But the microbiology clinched us the diagnosis, and we got the diagnosis of fungal endophthalmitis, and it was treated very successfully with intravitreal amphotericin B and oral fluconazole. So this is a classic example of a focus of infection in the eye that has come from somewhere else in the body. Similar example, this is a more recent case. You see a similar protrusion, which is not as obvious as in the previous picture. But if you look at the OCT running through that lesion in the left eye, you see this white cap-like lesion over the retina. And this has been called as the rain cloud sign. When you see this kind of a hyperreflective lesion on the surface of the retina with a choroidal backshadowing, you should think of candida. Of course, this is not a definitive diagnosis. You should go ahead with a vitreous biopsy and make the diagnosis. Okay. So this was also a patient who was not only diabetic, but had recently been diagnosed with COVID and treated with dexamethasone injection. So dexamethasone is a double insult, because on one hand, you are injecting a steroid which will cause immunosuppression in a patient who is already diabetic, but also because this is an invasive procedure and you can potentially introduce the organism into the bloodstream. This is another picture you see here. This is a more flat lesion, but you see that it's again involving nearly the full thickness of the retina. And this was a patient of multi-drug resistant bacillus endophthalmitis. You can see again the full thickness of the retina is involved. There is a reactionary inflammation in the choroid as well. And again, a septic focus in the eye from infection elsewhere in the body. Now, from such obvious pictures that you saw earlier, the two examples of candida, one example of bacillus, from that, we move on to something which is a little more subtle. Now, this, if you just look at the clinical photo, casually, then you may miss the diagnosis. But it is very, very obvious in the fundus autofluorescence and in the fundus fluorescein angiography on the top. This has a leopard spot-like appearance, which you see here. And this is syphilitic posterior placoid chorioretinitis. Okay, this is another picture of the placoid chorioretinitis that you see here in the right eye this time. And you see the outer retinal hyperreflectivity, which is so classical in the diagnosis of syphilitic retinitis. Now, many of these patients may have involvement of gentle ulcers, other manifestations of secondary syphilis. For example, there could be a palmar or a plantar rash. All of these are the other signs that will help you reach the diagnosis. Of course, the diagnostic test for these patients is getting a direct treponemal test done, such as the TPHA or the FTABS, and that will clinch you the diagnosis. So these are all examples of different bacterial infections that are affecting the eye. The last example that I'm giving here is, something lot more subtle. This was a patient, 34-year-old male, who had blurring of vision in both eyes and a diagnosis of typhoid 1 month back. Now, this is one concept that I want you to understand a little bit more. Now, this picture, some of you would know, is called as post-fever retinitis. Okay, so these patients typically will have a fever and then come to you with this kind of a retinitis and sometimes a neuroretinitis. Okay, a lot of people will call it an immune-mediated response, etc. But what really happens is that the eye is an immune-privileged site, which means that the immune surveillance within the eye is very limited. So if an infection somehow can break the blood-retinal barriers and land inside the eye, then it's very difficult for the immune system to find that infection, and it's very easy for that infection to multiply or spread inside the eye. That is how you get these kind of retinitis lesions, which are much more common after viral fever. But this is an example of post-bacterial fever, post-typhoid retinitis. Okay, so this kind of completes the different varieties of bacterial or fungal infections in the eye that are associated with systemic infections. But the main discussion that I'm going to have with you today is for the most common form of bacterial infection in the eye that is associated with a systemic infection, that is ocular tuberculosis. Before I move into this discussion, I will just stop and, in case you can ask any questions, I'm not sure if that is feasible. I'll be happy to answer those questions. Okay.
So we'll take the questions at the end, sir.
Okay. I thought it was getting too monotonous, so um, we could give it a break. Fine. So most of the remaining discussion is about ocular tuberculosis. Now, two myths that I would like to break in the remaining part of the presentation are that ocular TB can present with any form of uveitis. And the second myth is that if you get a positive MON2 or a quantiferon test, that would mean that the patient has ocular TB. Now, both of these are false statements, and they lead to a lot of diagnostic and treatment errors, as I'll be highlighting in the rest of my presentation. So the first point I want to emphasize here is that ocular tuberculosis has very select clinical presentations, and these have been listed in the Sun classification criteria. The granulomatous anteuveitis, serpiginous-like choroiditis, retinal vasculitis, and multifocal choroiditis. If any of these classification criteria have a positive TB test and you have been able to exclude sarcoidosis or syphilis, then you can make the diagnosis of ocular tuberculosis. Now, the common thing that binds all the four clinical presentations that I have listed here is the evidence of granulomatous inflammation. Okay, and this is published very nicely in literature. This is a patient of serpiginous-like choroiditis that had biopsy of the retina and the choroid, and you can see granuloma forming within the choroid. Similarly, this is a patient of TB retinal vasculitis where we got a retinal biopsy, and you can see a granuloma inside the retina. So, what will really give a diagnosis of ocular tuberculosis is the presence of granulomatous inflammation. If you do not see that, then the chances that you're dealing with ocular TB is quite low. Now, you should not only be looking at the primary clinical feature. For example, if you have a patient of retinal vasculitis, and you are thinking that this is tuberculosis or not, you should look at the other associated ocular signs as well. And these signs are listed over here. On top, you can see something called as subvascular lesions, which are either active or healed. And I'm sure most of you would have seen retinal vasculitis patients with these kind of healed lesions overlying the blood vessels, which we call as subvascular lesions. Also, something that we reported for the first time uh, called as focal vascular tortuosity, which is something that may not be visible very clearly uh, clinically, but if you do a fluorescein angiogram, you will see that within the vasculitis, there's a very clear-cut tortuosity of the vessel within the vasculitis. Okay, if you see that, again, suggests TB. And if you see occlusive retinal vasculitis in a TB endemic country, there's a very strong possibility that you're dealing with tubercular retinal vasculitis, unless there are signs of Behçet's disease or, let's say, an SLE retinopathy. So other than SLE and Behçet's, there are very few causes of occlusive retinal vasculitis like tuberculosis. Similarly, you should be trying to find other clues of tuberculosis. For example, could there be a TB contact, such as healthcare workers, migrant workers, barber, shopkeeper, etc.? Are there multiple tissues involved? For example, if a patient with choroiditis, which doesn't have any pain receptors, if you're clinically seeing a choroiditis where the patient is complaining of pain, it means that the sclera is also now involved. So involvement of multiple tissues will suggest tuberculosis. Similarly, if you see that a choroiditis lesion is extending into the retina, like in this patient, which is called as a contact sign, you should again think of tuberculosis. So multiple tissues involved is TB. So again, I'll try to tell what I mentioned in the previous slide, that there are specific clinical signs of TB, but when you come across any of those clinical signs, you should not look at them in isolation. For example, in retinal vasculitis, don't look at the vasculitis alone. Look at all the other features that are associated with the vasculitis, and that will help you reach the diagnosis of tubercular retinal vasculitis. I told you right in the beginning of the presentation that many of the bacterial infections that we come across in the eye and associated with systemic infection, the systemic infection may be occult, and these kind of clinical signs will help you reach the diagnosis. So all of these signs, when they present, they increase the pre-test probability of the disease. And along with that, if you get a positive TB test, you are likely to have a high post-test probability of tuberculosis. So the next point I want to highlight here is that getting a positive Montu or a quantiferon TB Gold test is not the same as a diagnosis of ocular TB. Now, these tests are only to understand a memory T cell response to a past TB infection. They do not tell you that the infection is actually there in the eye or rest of the body, or whether it is active or latent. Okay, so they may be positive in active TB or latent TB, or even when there is no TB infection. They just tell you the memory T cell response. Also, a lot of patients in whom the memory T cell response against TB has not developed very well, you may have a negative TB test despite the ocular condition being related to tuberculosis. I hope this part was understood. So these tests should be tested only if the clinical signs, which I discussed earlier, are suggestive of tuberculosis and not in the presence of opposing clinical signs. Most importantly, the MON2 test or the quantiferon TB Gold test is not a screening tool for TB in patients with uveitis. You do them only if it is required. I think if there is one message that you want to take from this presentation is, do not do these tests in every patient of uveitis as a screening tool, as a uveitis workup, but do these tests only when you're clinically suspecting tuberculosis. For example, this is a patient of placoid retinitis I mentioned earlier as well. You would not do a MON2 test. This patient, you would do a TPHA, VDRL, HIV, all of which were positive in this particular patient. Or this patient with a non-granulomatous anterior uveitis with fibrin in the anterior chamber and a history of inflammatory back pain, you're not going to test for tuberculosis. This is the HLA-B27 associated uveitis. Now, the funny thing is that in about 10 to 20% of HLA-B27 associated uveitis, that B27 test may be negative. Conversely, in about 40% of the Indian population, the MON2 test may be positive. Now, if you order the patient whose picture is shown here, if you order both MON2 and HLA-B27, and somehow this patient falls into that negative B27 group and comes to you with a negative B27 test, but a positive MON2 test, you will be in big trouble, because the treatment and the diagnosis of this patient will go in a totally different tangent, and the real diagnosis will be lost in translation. I hope this was understood. And finally, this is a picture of subretinal fibrin in CSR. This is not even an inflammation, not even a uveitis. Okay, but many people, if they are not able to make the correct diagnosis, they might order a bunch of tests, including a TB test, and suppose the MON2 comes positive, and you start treating this patient with ATT and corticosteroids, you know what will happen to this patient. It will go into a bullous CSCR. So be very careful in what test you are ordering in which patient. The size of the MON2 test really doesn't matter much. Okay, the 10 millimeter cutoff is kept because we want to rule out atypical mycobacterial infections, which can also give rise to a positive reaction, but usually the size of the test is less than 10 millimeters. Okay. But beyond 10 millimeter, whether you get a 20 or a 40 millimeter really doesn't matter much. I had a patient of actual VKH who came up, because somebody did a uveitis workup in that patient and got a 40 millimeter MON2, treated that patient with ATT alone, and the patient went into blindness because he was not treated appropriately for the VKH. Okay. Similarly, whether there are radiographic abnormalities in the chest or not doesn't affect what is the size of the skin test. Okay. So don't be swayed by the size of the skin test as long as it is more than 10 millimeters. Now, this is a question many of you will come across frequently when you refer a patient to start anti-TB therapy. Okay, the physician will see the patient and tell that, oh, this patient doesn't have any pulmonary TB, so it is unlikely that this patient is going to have any ocular tuberculosis. Okay. Now, to counter that argument, I am showing this study from Texas in the United States of almost 10,000 patients, at least 9,160 patients, of whom majority were pulmonary tuberculosis. Okay, but a significant number, 14%, were extrapulmonary tuberculosis alone. These patients had no signs of pulmonary TB. Okay, not only this, these patients also had a lesser chance of a past TB contact, and only about a third of these patients had abnormal chest radiographs, and just 1.4% of these patients had culture positive extrapulmonary specimens. Now, if you look at these numbers, these are so similar to the uh, to the uh, numbers that we see in ocular tuberculosis. If you look at the ocular TB data from the COT studies, you see similar numbers. Okay, 26% having a positive chest X-ray. Even if you do a CT scan, only about 70% will be having even an evidence of inactive or healed tuberculosis. So, getting evidence of TB in the chest is not needed for the diagnosis of ocular tuberculosis, just as it is not needed for the diagnosis of many extrapulmonary tuberculosis. Conversely, the presence of active pulmonary tuberculosis does not guarantee that there would be uveitis as well. Just 1.4% of active pulmonary tuberculosis patients have any evidence of uveitis. Now, from trying to tell you that the MON2 test should not guide the diagnosis of ocular TB alone, I'm now switching to the opposite side of the spectrum, where you have a strong suspicion of tuberculosis, but your MON2 test is negative. Okay. Now, this is a patient who had a totally scarred right eye, came to us in 2008. And in the left eye, which is the only seeing eye, you can see there is a active choroiditis lesion at the fovea as well as in the periphery. Okay. Now, this was 2008. I was relatively early in my practice, and I did test the MON2 and the chest X-ray. They were all negative. So I thought this is not TB and started the patient on oral corticosteroids. The lesions resolved but came back with a worse recurrence in 4 months' time. I gave more steroids. They resolved again, only to come back with an even worse recurrence, which you see in the picture. This time I added azathioprine. The lesions resolved alone again. But this time around, the patient was lost to follow-up, did not come to us for 2 years. After 2 years, when the patient came to us, you see how much of the fundus was scarred, okay? Which means that the steroids or the azathioprine were not working alone. And this is when we added the anti-TB therapy. And the patient has followed up for nearly 15 years since then, and there is no recurrence since that time. So getting a negative TB test should not also push you towards a non-TB diagnosis if clinically the picture is very suggestive of tuberculosis. So when you get these kind of negative TB tests, you should be ruling out every other differential that could possibly cause that kind of clinical picture. For example, for choroidal tuberculoma, these would be the differentials. Find an alternative evidence for TB. A chest radiography is a very good option. You can do both abdomen and chest radiography. Look for other evidence of extrapulmonary TB. Take a very focused history of TB contact. Okay. And obviously rule out all other alternative diagnosis. And that is how, you may be able to reach the diagnosis of TB, even though your MON2 or quantiferon is negative. Sometimes repeating these tests also helps, especially the quantiferon TB gold test you could repeat. And if the immune response was in the evolution stage, then the repeat test may come out to be positive. In fact, this happens very commonly in extrapulmonary tuberculosis. Up to 30% of all extrapulmonary TB can have a negative quantiferon TB gold test, and this is especially more in CNS tuberculosis. Even in ocular tuberculosis, which is microbiologically proven, up to 40% can have a negative MON2 test and 57% a normal chest X-ray. Okay. Now, if you have made a good diagnosis of tuberculosis, the results of treatment can be very gratifying. And these are a few pictures that I show you. This is a patient who came to us with a TB retinal vasculitis and an active retinitis lesion on the blood vessel, which you see there. We treated with ATT alone, and in just 2 weeks' time, you can see that the lesion has disappeared completely. Okay, it's that gratifying. This is a patient of serpiginous-like choroiditis who came to us with a vision of 20/50. The patient was also a diabetic, so we had restrictions with what steroids we use. We added Ozurdex to overcome that limitation, and with anti-TB therapy and systemic and local steroids, the patient responded very well, and we got a vision of 20/20 from the 20/50 6 months later. So that kind of gratifying response. These are two patients of choroidal tuberculoma. You can see both were treated with anti-TB therapy alone, and you can see how the lesions are melting away in just 2 weeks' time, and then almost gone in 5 weeks if you have made the correct diagnosis. Okay, but a correct diagnosis will only come when you are able to identify the specific clinical signs, and you are able to use the TB test properly and not use them as a screening tool. Conversely, if these patients are treated with steroids alone, not giving anti-TB therapy, the initial result may be gratifying. You can see this patient who came to us with serpiginous-like choroiditis was given steroids alone, the vision improved, the lesions appeared to be resolving, only to come back with a vengeance, and you can see much larger lesions, vision dropping down from 20/25 to 20/50 and dropping down further to 20/80, as can be seen in this patient. Now, there are situations where, despite anti-TB therapy and steroids, you may have a worsening. If that happens, try to rule out an alternative diagnosis always for the given clinical finding. But for serpiginous-like choroiditis, such a worsening can also happen due to paradoxical worsening, which has been described in many other forms of tuberculosis as well. The size of the lesion and something we call as dual margins, these are some of the predictors of the paradoxical worsening. Sometimes the recurrence can be late after starting anti-TB therapy and steroids. Again, ruling out a non-TB etiology is very important. And then you think of drug resistance and a recurrent drug-susceptible TB as well. Now, this recurrent drug-susceptible TB could be due to an endogenous reactivation, a relapse, or a reinfection. To summarize the TB thing, clinical signs should decide whether you test for MON2 and or quantiferon. The MON2 is not a screening tool for uveitis workup. Avoid it in non-TB clinical signs. The positive TB test is irrelevant if you are dealing with a non-TB disease. Similarly, a negative TB test does not rule out ocular TB. I hope this was useful, and now I'm open to all questions.
Thank you so much, sir, for that wonderfully articulated class. We have some questions, sir. Am I audible?
Yeah.
Yeah. One second. Mm, Yeah, so if a patient presents to the IOPD with signs of endogenous of endophthalmitis, what all systemic investigations should we begin with to pinch the primary source of infection? Because it's difficult to localize the cause in a lot of cases when we see the patients in real life.
Yeah. I think a good history is very important, and the history that is often missed, uh, specifically for endogenous endophthalmitis, is of a history of IV infusion. We do not have too many drug abusers coming to us, but an
Mhm.
IV infusion. So typically, the patient would have had fever a few weeks ago, and he would have gone or she would have gone to a quack who would have treated with a IV infusion. And that IV infusion is the source of the endogenous endophthalmitis. Most often, the bacteremia or the fungemia that leads to the endogenous endophthalmitis is very transient. So, getting a
Mm.
positive blood culture is very, very rare. Similarly, a urine culture may be, in case it started from a urinary tract infection, may be positive, but a lot of times that urine culture may be unrelated to what is happening in the eye. So
Mhm.
the best option is to go inside the eye, do a biopsy, get a microbiological diagnosis, get a sensitivity analysis, and then treat the patient.
But even with that, we might still not know what the origin or the cause was of this endogenous, even after getting the biopsy result, right?
That's true, but once you get that, your primary goal at that time is to save the eye, and assuming that the patient doesn't have any other manifest, systemic presentation, for example, a UTI or a lung infection, anything. Okay, that of course is mandatory to undergo a physician evaluation, because the physician should examine for all of those things. And assuming that none of those have been found, your
Mhm.
goal primary goal is to save the eye. Okay,
Okay, so
so if you save the eye, and you have to give systemic antimicrobials to these patients. Okay,
right.
so when you give those systemic antimicrobials, they will take care of the systemic infection as well. This is not like cancer where you need to find out the primary, right? Because that
Mm-hmm.
the approach goes on a different tangent. This is an
Right. So,
infection, right? So
okay.
that's how it is.
So this is often a very much debated question. What is the role of steroids for endogenous endophthalmitis?
I think once we have reached a microbiological diagnosis and we know the sensitivity of the drug, there
Mm.
should not be any hesitation in using steroids in these patients. Okay,
Okay.
but most of these patients, they respond to systemic antimicrobials very well, be it antibacterial or antifungal.
Mm-hmm.
Compared in my experience, compared to, and I'm talking obviously, and fungal infections are out of the picture here. Fungal, you are not giving any steroids. But
Mm-hmm.
talking only about bacterial infections, the need for steroids is much more in post-traumatic or post-operative endophthalmitis. Okay. In endogenous endophthalmitis, the need for steroids is relatively less. It
Mm-hmm.
responds very well to the antimicrobial therapy.
Okay. Like you already said, that the best idea is to go inside the eye and get a vitreous sample and then treat accordingly. So, vitrectomy would be an indication for all cases of endogenous endophthalmitis as a primary
Absolutely.
intervention.
Absolutely. Yeah.
Okay, fine. Okay, so
Yeah.
okay. So what blood culture techniques or biomarkers would improve yield in suspected fungal systemic infections with ocular seeding? Is there anything specific?
Uh, I don't have a good answer to that question. But as I told you, the bacteremia or fungemia is very transient in these
Mhm.
patients. And I'm talking only those that do not have any manifest infection. Okay. So, since it is so transient, uh, it is all, most of the times it's not very fruitful to get a bacterial. Or again, you know, if there are no systemic manifestations, beyond a
Mhm.
point, it doesn't make much sense chasing the systemic focus of infection. This
Right.
is not cancer, this is an infection we are dealing with. Okay. A
Mhm.
primary goal should be to save the eye. Okay.
Okay.
Assuming that the physician has done a thorough evaluation. Okay. And
Mm.
it's not just the ophthalmologist, but the internist has done a thorough evaluation. Okay. Beyond that, you do your blood and urine culture, of course, but that's about it. Of course, one of the things that is very obvious is that you would try to do that before starting any kind of systemic
Mm.
antibiotics.
Mm.
Okay,
Mm.
so that's a very obvious thing. But other than that, really nothing much.
Okay. So considering your great interest in TB, could you give us a brief outline of the intraocular TB based on COT study, COT?
Yeah. So the value of the COT study is that it has got uh, inputs from all over the world. Okay,
Right.
so it's like a global study. Okay,
Mm.
that's the one good thing. The other good thing is that they try to create a scoring criteria
Mm.
for the COT scoring and the app that is available to score and make a diagnosis. But these are the two good things. The problem is that a lot, COTS is a consensus based study. So
Mhm.
you have like 80 different ophthalmologists, and you ask for a consensus, and based on whatever is the consensus, you make the guidelines. Okay, so the word consensus should be very clear. Okay, now while everybody who entered the COT study, I'm sure, was a good expert in uveitis, that is how they got their entry into the study, but their exposure to tuberculosis would be very variable. So for
Mhm.
example, those that are from India, or let's say, you know Indonesia, okay, or Singapore, those people would have been seeing more cases of TB. Okay, but if you look at the majority of the participants of the COT study, they are from TB non-endemic countries who would be seeing very little TB. Okay,
Mhm.
so basing a consensus on the experience of people who hardly see the disease, I think is not very appropriate. Having said that, I'm pretty sure that uh, a lot of uh, you know work is already going on. It's a very motivated group, the COTS group. Okay,
Mhm.
and I'm sure we are going to see a lot more refined versions of the COTS, consensus. That
Mhm.
would be more useful than what is currently available.
Mhm. Okay. So we that actually is in continuation with the next question that we had, that how relevant is application of COT study across India, and does it change because of the geographic variations and the regional differences across the country?
That's a great question, I think. Okay,
Yeah.
because the way the COTS has been developed, while there are markers for endemic versus non-endemic, it really doesn't tell you whether the TB is different between two non-endemic areas. I mean, two
Right.
endemic areas. Okay,
Exactly.
I'll give you my personal experience. So I worked for almost 14 years in Bhubaneswar in Odisha. Okay,
Hmm.
and for the past 5 years, I have been in Hyderabad in Telangana. Okay,
Hmm.
now the type of ocular TB that I was seeing in Bhubaneswar was very different from the type I'm seeing here in Hyderabad. So these are relatively neighboring states, right? Orissa and Hyderabad. And if I can see, so Orissa was primarily retinal vasculitis. Okay. Of course, we were seeing a lot of serpiginous. We saw so many of those tuberculoma that I showed in my presentation. But in Hyderabad, I am seeing a lot more pan-uveitis. Here, the inflammatory response is much stronger than what I was seeing in Odisha. So here I see a lot more panuveitis, a lot more serpiginous. These are way more common there. And I rarely get to see any TB retinal vasculitis. I mean, it's an event if I see a TB retinal vasculitis in the clinic. Whereas in Bhubaneswar, I would see it in almost every other, OPD that I had.
So coming to the big, huge spectrum that TB is, so we had some experience with an IgG4 related disease patient who was initially diagnosed as TB. Maybe because there is a huge overlap in the signs and symptoms. And then later, when we finally arrived at the diagnosis of IgG4, the entire management obviously changed. So, is there, sir, any known association or any way in which this sort of overlap of diagnosis can be prevented, or how can we better manage these patients to avoid this overlap?
So these overlaps will come. And,
Right.
in my experience, again, your ability to diagnose TB, is based on your ability to rule out what is not TB. And in
Mm-hmm.
that sense, I feel that my skills in ocular TB are still evolving because I'm also learning to rule out what is not
Mm-hmm.
TB. And I'm definitely way better than what I was, say, 10 years ago or 15 years ago. Okay.
Right.
So that thing will come. Now, IgG4, while it has a lot of overlap with ocular tuberculosis, is also a rare disease. Okay,
Mm-hmm.
it's not a very common disease, right? So, there would be these overlaps. There would be times when you would be, stepping into something which is not tuberculosis. But you will also get as long as you remain alert, you will also get the opportunity to, you know, make amends and come back to the original diagnosis. It is not
Mm-hmm.
just about IgG4. There are several other things where you can potentially get mixed up. We have a
Mm-hmm.
paper where, a patient of sarcoid was called as TB, or a patient of TB was called as sarcoid. And this TB sarcoid thing keeps on happening all the time. Okay. Especially because a lot of biopsy proven sarcoid patients in India are Monto test positive. Okay.
Mm-hmm.
So, this is something that I cannot put in a single answer. This will come up as you practice and see the patients.
So, sir, when we are suspecting tuberculosis, considering the huge list of close differentials that could be with TB, who should test like serum IgG4 be a part of the panel amongst other
No,
tests
no.
which should be
So,
done?
you know, I didn't get into that discussion here. The, you know, value of a test in uveitis, or for that matter, any condition, depends on the pre-test probability. Okay, we didn't go into that much. I'll give you an example of ANA. Okay,
Hmm. Hmm.
then you will understand why not IgG4. Okay, so ANA is actually a very sensitive test for the diagnosis of SLE. Okay, but the prevalence of SLE amongst isolated uveitis patients, and I'm not talking about pediatric uveitis, only adult. Okay, in adult uveitis, the presence of SLE is very rare. Less than 1% of adult uveitis are due to SLE. Okay, so when the prevalence of SLE is so rare in adult uveitis, especially if there is no systemic manifestation of SLE. Okay, so you're not seeing the malar rash or any such thing. Okay, just getting an ANA positive, the post-test probability of a positive ANA test is very low. It is less than 1%. You get the point? Similarly, for your IgG4 also, suppose your IgG4 comes out positive, but you do not have the other signs of, IgG4 disease in the patient. The post-test probability of getting a positive IgG4 is very low because the prevalence of IgG4 disease itself is very low. And therefore, the pre-test probability of IgG4 is very low. Did
Got it.
that make sense?
Yeah, it did.
Yeah.
Right.
So
Yeah.
with such low pretest probability, even a positive test is not going to yield you a lot of benefit, assuming that there is no other manifestation of IgG4 disease.
So, sir, keeping IgG4 apart on a practical day-to-day basis for postgraduate level, what would be a concise, precise battery of tests that should be given when we are first suspecting TB? I mean, in closed differentials.
So I'll start with the last few words of your question,
Mhm.
suspecting TB,
Right,
and then comes battery of test. Okay.
right.
If you are not suspecting TB, don't do the test. This is the single message that I want to tell today.
Okay.
Not suspecting TB, don't do the test. Okay. And I told you, you should typically have some evidence of granulomatous inflammation. Now, if you remember that list, intermediate uveitis was not there in that list.
Mhm.
Non-granulomatous anti-uveitis was not there in that list.
Mhm.
That doesn't mean that TB cannot cause intermediate uveitis. Okay, TB does cause, but it's a very rare cause. Typically, you need some evidence of granulomatous inflammation like the ones that I mentioned there. So if you have all those things with you, it means that you are strongly suspecting tuberculosis clinically. First thing is get a good history of TB contact. Okay. Not a casual history. Oh, did anybody in your family have TB? No. What job do you do? Are you a migrant worker? Are you a barber? Or, a healthcare worker? Anganwadi worker is the best example. They go to distribute the TB medicines. The easiest way to get the infection. Get a good thorough history of TB contact. Okay. Then, since you are strongly suspecting TB, advise both the Montu and the quantiferon. Not because one is better than the other, but because suppose one is negative, the other positive test will give you the help you start the treatment. Okay. So advise both. And the two important things that you need to rule out are sarcoidosis and syphilis. That is mandatory in all these patients. Sarcoid is ruled out by a chest imaging, not by a serum angiotensin converting enzyme. And syphilis is ruled out by a TPHA and not by a VDRL. Never advise a VDRL for the syphilis. Okay, it's cheaper or whatever. It's TPH or FTABS. FTABS is way more expensive. Okay, so you have to advise a direct treponemal test. Then there could be a specific situation. For example, a Behçet's disease, you would want to look for uh, oral gentle ulcers, etc., etc. Those are unique, but syphilis and sarcoid are absolutely mandatory.
That was a really nice, a good take-home message, I think, for most postgraduates, because I think a lot of us have done this when during our residency, where serum ACE and VDRL has been given more commonly for both these conditions. All right. So one last question. In interest of time, we'll be taking this as the last question. What are the clinical signs of chorioretinitis to differentiate between an infectious or an inflammatory pathology, just clinically by the look of it?
Yeah. So when you say the word chorioretinitis, it means that the retina is involved.
Yes.
And if the retina is involved, that is infection. There is only one major non-infectious condition that causes a retinitis. Would you know that? Which one is that?
Non Besh,
Non-infectious Behçet's. Perfect.
Besh,
Okay.
no,
But
Behcet's.
Behçet's will cause a transient retinitis. You order a bunch of tests, 1 week later, the retinitis is gone. Okay.
Mhm.
So apart from Behçet's, anything that is retinitis is infection. And you have to look at the morphology of the retinitis to decide, which infection you're dealing with. If it is a chorioretinitis, which is different from a retinochoroiditis, retinochoroiditis is toxoplasma most often. Okay. But when you're talking about chorioretinitis, it means that the primary lesion is in the choroid and then it is kind of breaching into the retina. That is tuberculosis. I showed you the OCT of the contact sign. It needs a breach uh, of the RP and Brooks membrane. Okay, that would be tuberculosis. Okay.
Alright. Okay. Thank you so much, sir. That was really a great talk for most postgraduates, considering how confusing this whole spectrum is. We'd like to end with letting all our viewers know that the next session would be on 4th of July on Eye and Systemic Viral Infections by Dr. Padma Malini Mahendra Das. And before we all leave, one last message to all the viewers. Just a second. Is my screen visible?
No.
No, doctor. Yep.
Just a second. Now?
Yes.
Yeah. So, to all our viewers, this is a very close call for iFocus, physical iFocus that's being held in Delhi this year from August 10 to 17. Please grab your seats quickly. They're getting filled up very, very soon, and you really do not want to miss the event of the year for postgraduate ophthalmology education. This is really going to be an experience that is going to expose you to a lot of stalwarts from all the different subspecialties in the subject, and you want to be in the place where all of them are going to be on the same platform, giving you all the experience that they've had so far. Thank you so much, sir.
Thank
Thank
you.
you.
Thanks.